Hello everyone, I'm Dr. Abhishek Vaish. I'm consultant in orthopedic surgery at Apollo Hospital, Delhi. So today I'm going to talk about a very interesting topic, that is spine surgery, but when to do it and when not to do it. So we will first look into how to examine the patient, how to take history, how to classify spinal pathologies. What are the most common problems which we see in our daily practice? What are the treatment algorithms? And at the end, we will discuss based on some interesting cases and we will come to a diagnosis. So, in 2021, a majority of people, 600 plus million people, had back problems. And this number is only increasing because of the growing population and the number of old people is increasing every day, every year. The cost is tremendous to treat these patients, but we should know it is very important that we know that conservative management is beneficial in more than 80% patients. Not everybody needs surgery, and surgery is only required in few selected patients who have severe problems and are not getting better with conservative management. So, how do we know which patients to operate and which not to? That's what we are going to see. History taking is the most important thing. So, how do we take history? Take the personal data of the patient, where the patient comes from, what is his occupation, what is his age, then find out about the pain. There is a mnemonic Socrates, we will talk about it. What is the neurological status of the patient? What are the red flags? Any other important past history, medications, or any family history? So let's see. First, personal data. Age, why is it important? Because different pathologies have predilection to different ages. Place from where the patient comes from is important because some diseases are more prevalent in specific areas. Like if we talk about infection in general, it was earlier known that it was more common in Bimaru states, that Bihar, MP, all those places. So if we know where the patient comes from, we can diagnose many conditions. And occupation is important because we need to know whether the patient has more of physical activity or he's a sedentary worker. So if we come to pain, we can remember we have to know all the aspects of pain. So if we know the mnemonic Socrates, S stands for site, where the pain is originating from. How is the onset? Is it more painful in the morning, afternoon, evening? What is the character of the pain? Is the pain more shooting like? Is the pain dull aching? Is the pain aggravated on doing some activity? Is it more at night time? Is it more on daytime? Is it getting relieved by doing some other activity, or is it radiating, moving to another area when the pain starts? So, all these are very important and it helps us clinch the diagnosis. Neurological signs, you need to see if the patient is having any neurological deficit or not. What are the red flags to look for if the patient has had trauma, unexpected weight loss, worsening of neurological symptoms? If the patient is more than 50 years of age, fever which is not settling, or it's on long-term medications like steroid, or have family history of cancer. So these patients are high risk for severe pathologies of the spine, could be malignancy, could be traumatic unstable fracture, we need to see, and if these red flags are there, we need to treat the patient ASAP. Any other past surgical history around the spine or any other where in the body. Probably some patient may have malignancy elsewhere in the body for which they were operated. If you ask this history, then you can suspect a secondary in the spine, which will clinch the diagnosis. And is the patient taking any steroids? Is the patient having any family history of smoking, alcohol, social? All these things are really, really important. So you should know how to differentiate pain. Is the pain inflammatory in nature or mechanical in nature? It is very simple if you follow this chart. So inflammatory pain is more common in patients who are less than 40 years of age. Mechanical pain can happen to anybody of any age. Inflammatory pain is slow and chronic. It is there for a long time. But mechanical pain happens when the patient has done some activity in the near times. Like a patient may come to you and say, Doc Sahab, I was dancing in a party yesterday, and since then I'm having a pain. So that is mechanical pain. Symptoms are long time in inflammatory and the stiffness which happens mainly in the morning when the patient gets up. That is a feature of inflammatory arthritis or inflammatory pain in the spine. And what usually improves the inflammatory pain is doing some movement or exercise. But in mechanical pain, the opposite happens and it worsens. And sometimes in conditions like ankylosing spondylitis, there is reduction in chest expansion, and in mechanical, the chest expansion is normal. So we know that prevention is better than cure. So we should aim to diagnose or identify the problem or the problem which may occur because of bad posture or other lifestyle habits, and we should try to warn the patient as so that they can prevent a severe back problem. So how do we prevent? First, tell the patient they should lose weight because if you have a big belly, then your the lumbar spine starts to get flexed, and that is when your muscles in the back are under strain. So proper weight reduction, posture is very important to maintain a good spine, a healthy spine. So you see some pictures here where they show how to sit in a car. A simple change in habits can relieve you from a lot of problems because you use a car every day, use a chair every day, you walk every day. So if you correct your postures, you can, in the long run, prevent a lot of spine problems. Next is when you're lifting heavy weights from ground, you should try to bend your knee and then lift a heavy weight rather than bending your back and lifting the heavy weight. Similarly, try to use pulley systems or use of other trolleys if you are a manual worker so that you can reduce the load on your spine. When sleeping for your neck, it is very important. Your neck is usually in lordosis. So it's like a reverse C. So to maintain that reverse C, you should support your neck when you're sleeping rather than putting a thick pillow under your head, which will worsen the pain in the neck. Other treatment options non-operatively are the patient in short term can go for some modalities like interferential therapy, short wave diathermy, TENS. You have heard about these modalities. Then there, in the old times, There used to be wax therapy, traction, which are also used nowadays sometimes. And also, the patient can be treated with manual therapy and other exercises. So, patients who are not getting better with uh, conservative management, some medicines, and are persisting to have pain may require surgery. So, surgery is done once you are confirmed and sure of the diagnosis. The patient feels that he's not getting better, and you know what the pathology is, and you are sure that you will be able to relieve the patient uh, permanently of these problems during a surgery. So, patient selection is the key, and you should warn the patients about the complications, about the healing recovery time, rehabilitation time before you go and opt for a operative procedure. So in general, if we are talking about surgical procedures, absolute indications would be if the patient are having neurological worsening symptoms like bowel and bladder involvement, like Corda-Equina syndrome, which we will be talking about, or the patient has had a conservative management, not getting better, recurrent, reappearing sciatic pain, and poor reduction in the power of the muscles, and also having significant neurological deficit. There are a lot of surgical procedures which can be done based on what pathology that we are going to cover in a short while. So, these are some pictures showing that in this case, there was a total laminectomy done along with fusion. You can see these rods on either side of the spine to give stability to the spine. Then there could be laminotomy, laminoplasty, multiple procedures which we are going to talk in this presentation later. So before we start, let us classify our spine problems so that we can go in a systematic way. So it can be a congenital problem like deformity, scoliosis or kyphosis. Then there could be trauma due leading to disc prolapse or fractures. Then there could be old age problems which lead to spinal canal stenosis. There could be infections which could be bacterial or tubercular, or there could be, uh, you know, problems like osteoporosis, which happens in old age, which lead to fracture with a trivial fall. So we are going to see all these conditions and how to treat and when to operate. So, if there is a patient you see with congenital deformity, do all deformities require surgery? The answer is no. So, when the thoracic spine usually is bent forward, this deformity is called a kyphosis or kyphus. And when there is a C-shaped or double C-shaped deformity in the spine, then it is called scoliosis. So, this is the algorithm for treatment. If there is a mild curve, that is 10 to 20 degrees of curve, and the growth is, if it is completed and the patient is having no symptoms, then usually no treatment is required, only observe the patient every 6 monthly. If the growth is not completed and you see the child is growing in height. So you need to observe again. And if the deformity is getting exaggerated, suppose you come into the category of 20 to 45 degrees, and then you can use some braces so that the growth is in that pattern. But if that is also not helping and the curve is more than 45 degrees, then you may need to do surgical correction of this deformity. And the other indication of correction or deformity are if the patient is unable to walk, he is having poor neurological symptoms, and the pain is worsening, and they are unable to do their activities of daily living like sitting, lying down. Then are the, these are the indications to operate patients. So you can see these are some X-rays showing multiple level fusion and deformity correction. So these are major surgeries. So the plan to operate should be well made pre-operatively and talk to the patient, and then only these patients should be taken for surgery. And it is very important that these surgeries are done only by experienced surgeons. So there are many ways you can do post. This is all posterior deformity correction, and in some cases there could be anterior deformity correction, like in kyphosis. So yeah, this was done anteriorly. You can see the deformity is fully corrected, and there was also fixation of the sacroiliac joint in this case. So next is trauma. So some patients will present to you with spinal cord injury, fractures, or disc prolapse. So let's see what is a spinal cord injury. It could happen due to road traffic accident, a bullet or stab injury, a fall from a pole, electric shock, twisting of the body during violent attacks, or landing on your head during sports injuries. So a spinal cord injury could be either complete or incomplete. Incomplete injury, the patient may land up with tetraplegia, that is paralysis of all four limbs, or paraplegia, that is paralysis of the lower limbs. Incomplete spinal cord injuries could have multiple syndromes, could present in different ways, such as central cord syndrome, posterior anterior syndromes, Brown sequestered syndrome, and Corda-Equina syndrome. Corda-Equina syndrome is the most common and seen, so we will discuss about that in a while. So, what is the emergency medicine, emergency management of such cases is first of all immobilize the patient. If it's a cervical problem, give us hard cervical collar. If it's a lower spine injury, then put the patient on a spinal board and see if the airway, breathing, circulation are in place. If not, you follow the ATLS guidelines to stabilize the patient. Then nursing care is very important in cases of quadriplegia or paraplegia, because these patients cannot move. They have loss of motor function. So then they require a lot of things, like they need their urinary bladder to be relieved uh, after every certain time with hygiene. Their bowel need to be taken care of, fluid management, and also their mental health. So the nursing goals should be to take care of the cardiovascular, respiratory, GI, genitourinary, musculoskeletal, um rehab, dermatological management. So there are a lot of aspects. A spinal cord injury patient needs a multidisciplinary management to get good results. In cases of fractures, suppose the patient has a fall from height, there could be burst fracture, anterior column fracture, posterior column fracture, or a through and through fracture. So, in short, if the fracture is unstable, which can be diagnosed once we have a CT scan and an X-ray, based on that, we classify the patients. And if it's a A3, B3, C3, or B2 fractures, then we need to operate the patient. But if it's a stable fracture, then most of the times we can get away by not operating the patients. So these are the indications of surgery. If the patient has no neurological deficit and there is no malalignment, then these patients usually do not require any surgery. But if there is some malalignment and you see, but you can correct it, and the alignment is acceptable, then you may not require surgery. But sometimes, if the alignment is not adequate, you can correct the alignment using tractions or open reduction and then stabilizing the spine. But if there is a neurological deficit, then these are indications for immediate surgery. In case there is some malalignment with the bones, then you need to again put screws and rods to correct the alignment. If there is no malalignment and there is only a disc prolapse, which is compressing the nerve, then you fix the fracture and remove the compressing part of the disc so that the nerve can get free. Third comes a prolapsed intervertebral disc. So, how does a patient present? The patient will say that I am having radiating, shooting pain in the lower limbs, which will follow the dermatomal distribution. There may or may not be history of bowel and bladder involvement. There could be saddle anesthesia, and the patient on examination will have a positive straight leg raising test, which signifies nerve irritation and compression. These are the three stages of disc problems. One is protrusion when the annular ligament is still intact but it is still protruding. Extrusion is when there is a tear but there is some contact with the normal disc, and sequestration is when the disc contents come out and flow in the canal. Usually, diagnosis is clinical, confirmed on MRI, and management is first of all, if it's an acute case and there are no neurological symptoms, you may try with simple painkillers, muscle relaxant, bed rest, and some physiotherapy. But if it's a chronic problem or if the patient is having neurological symptoms, then you may need to go for surgery. So you need to identify the area where the nerve is getting pressed. It could be a paracentral disc herniation or it could be a far lateral disc herniation. This is important to plan your surgery. So if it's a central disc herniation, you may need to change your approach surgically, or you may need to just do a laminectomy. But if it's a far lateral disc, you may use a loop or a microscope to remove the disc from that place. So if you know what you're looking for in the surgery, then the surgery is successful. So this is an MRI which shows that there is a disc herniation in the L5S1 region, which is compressing the nerve. And you can see the nerve is completely obliterated, and you can hardly see the free flow of CSF. And these are the cases, and it's on the left side. So the patient, you have to correlate clinically. If the pain is in the left side in the same dermatological distribution, then you need to release this nerve to get good results. So first try with non-operative management for a week, 10 days. If not, then you have to operate. So if there is no instability in the spine, then simple discectomy would do. There are many ways by which you can do is one is open, another is micro discectomy, endoscopic, percutaneous, far lateral. There are many ways nowadays. Now, robotic spine surgery is also coming in a big way, and maybe in the future, 2 or 3 years, we will see robotic discectomies happening. If there is instability in the spine, then with the removal of disc, we may need to fuse the spine using screws and uh, rods. And there are many ways which by which we can do this. One is P-lift, another is T-lift. These are just techniques how you fix these spines. Uh, so microdiscectomy is, as the name suggests, removing a part of the disc which is pressing the nerve. Indications are pain more than 6 months, progressive weakness in the limbs, or the patient presents to you acutely with Corda equina syndrome. The chances of recurrence are around 20%. So if not done correctly or if not done by an experienced surgeon, the patient's chances of nerve damage is high. There could be bleeding from the vessels around that nerve, and the chances of infection are always there. So you can see the incision is quite small, around 2 to 3 centimeters. And in this was a case of central paradiscal discectomy. And you can see such a big part of the disc had to be removed because this was compressing the nerve. Another indication, if you talk about infections in the spine, so infection can be categorized based on where the infection is happening. It could be paradiscal, that is around the disc. It could be central, that is in the center of the vertebral body. It could be anterior in front, or it could be in the posterior elements. So usually the infection in the spine could be either bacterial, fungal, or due to atypical or typical Mycobacterium tuberculosis. So in Indian subcontinent, we see more of tuberculosis infection. What are the symptoms? Back pain, stiffness, night cries, paraplegia, or deformity, gibbous, or the patient may have pressure symptoms like dyspnea, dysphagia, hoarseness of voice, and constitutional symptoms like weight loss, night cries, fever. So when you see the patient walking, you can clinch the diagnosis. If it's a cervical problem, the patient will have a typical attitude. Similarly, thoracic spine problem, military attitude, or lumbar lordosis may be exaggerated. There will be tenderness, there will be deformities, and the patient may also complain of constitutional symptoms. So the most common complication of tubercular spine is Pott's cold abscess. This happens in 20% of cases. It contains tubercular bacilli and debris, that is caseating material, which clinches a diagnosis. This material should be sent to the lab to identify the organism and start treatment. Also, the patient can present with lumbar abscesses. These are the various places where the abscesses can happen. So it could happen either in the dorsal lumbar fascia in the back, or the psoas fascia, that is called the psoas abscess, somewhere around here, or there it could be in the ischiorectal space, that causing the ischiorectal abscess, or in the Petit's triangle. So if you know where to look for these abscesses, you will not miss, and hence you can treat the patient in time. X-rays may show severe osteopenia, reduced spaces, lytic destruction, collapse in the vertebra because of the weakening of the bone, deformities like gibbous, and soft tissue shadows if there is paraspinal abscess formation. So, how do we approach cases of infection? If you have suspicion, then do simple blood tests like complete blood counts, CRP, whole blood counts, blood cultures. Then do a plain X-ray of the chest as well as of the spine. You may require to do MRI to see the soft tissues or abscess collection in front of the spine. If the MRI comes positive, then you confirm the diagnosis of spinal infection and you start your treatment. But if MRI is inconclusive, then we sometimes may require to do radionucleotide imaging. Osteoporotic fractures again are very common nowadays because the increasing number of old patients and the age as well. So, such patients will come to you with history of very minor trauma, like we just fell down in the bathroom, or we were just turning in the bed and we heard a crack. So these, because of severe deficiency of calcium or osteoporosis is happening in the spinal bones. That is why they are breaking, and this may cause compression on the nerve and hence pain. So it is very easy to diagnose osteoporosis if you know, if you're aware, then there is something called as DEXA scan, where usually a three-region DEXA scan will take areas like wrist, spine, and hip, and it will tell you the chances of you getting fracture compared to a normal patient of that same age. So, what is the management? Again, if there is suspicion of compression, you do an MRI. First of all, the patient should be immobilized, do bed rest, and if it's not compressing the nerve, the simple medicines of pain relief and strengthening of bones with the help of calcium, vitamin D3, and anti-osteoporotic therapy will help the patient. But if there is a neurological symptom which is coming, then in such cases we use this algorithm. If there is a patient is unable to sit upright, then we may do something called as kyphoplasty or balloon kyphoplasty. If the patient can sit in a upright position. Sometimes we may also do vertebroplasty, that is just injecting some cement into the fractured bone. But if there is more than 50% loss of height in the vertebra, then we may require a screw fixation in such patients. So this is like a balloon. This is what kyphoplasty is. We put a needle in the vertebra with a balloon. So once the balloon is inflated, the height of the vertebra is maintained, and through this cannula of the tube, we inject cement which settles here. And in vertebroplasty, there is no balloon, there is just cement which has to be pushed. So this is the difference between vertebroplasty and kyphoplasty. So very important, cauda equina. This is a medical emergency. If you see, you should know what are the symptoms of cauda equina, and if you see such patients in your clinic, then you should immediately refer such patients for further management. So the patient will have severe back pain with bladder and bowel dysfunction, saddle anesthesia or numbness in the groin area, and shooting pain in one or both the legs. So immediate decompression is required in such cases, and after surgery, the chances of bladder bowel function return is around 90% if done within the first day, and it reduces to around 80% within the next 2 days. And if it is more than 2 days, then the chances of recovery are less than 50%. Next, we come on to aging problems like spinal canal stenosis. So, 80% of your um, clinic will have patients having spinal canal stenosis. But do all patients require surgery? The answer is no. So treat these patients by taking a history, checking them clinically, and then if there is no neurological symptom, try with simple lumbar corset belt, physiotherapy, medicines to reduce pain, strengthen the bones. But if these patients are not getting any better, then we may think of doing something more for them. But before that, you should know what is the difference between a vascular claudication and a neurological claudication. That is very important because sometimes the patient may have a vascular claudication, but you may treat it as a spine problem. So, if the walking distance is fixed, then it's a vascular claudication. Otherwise, if it is variable, then it's a neurological claudication. Uh, if the pain is aggravated by walking, then again it's vascular, and if it's aggravated by standing, walking, or doing whatever, then it's the neurological. Walking uphill is very painful in vascular claudication, but it is painless in neurological. And if you see that there is in a vascular claudication, rarely there will be any weakness in the lower limb, but in neurological there could be some neurological symptoms. And cramping is present in vascular pain, but it is absent, and rather there could be numbness. So you should differentiate such patients, and you should know if you are dealing with a spine problem or a vascular problem. So first treat with non-surgical methods like medicines, physiotherapy, bed rest, use of bone strengthening agents like calcitonin, modalities like TENS. If all this is not working, the second line of treatment is an epidural steroid injection, which shrinks the uh, compressed nerve, which shrinks the disc which is bulging out to a certain level, soothes the pain in the nerves. But if this is not working, then you may need surgery. By surgery, we mean laminectomy, laminotomy, laminoplasty, and if there is instability, then we also may need to fuse the spine using screws and rods. We will also see patients who are having a problem called as listhesis. So, what is listhesis? Listhesis is when there is anterior displacement of one vertebra in relation to the vertebra below. And this could happen because of multiple problems, like there could be a pars defect since childhood, there could be a traumatic spondylolisthesis, or there could be a degenerative spondylolisthesis. So, how to identify listhesis? Just do a dynamic X-ray, inflection and extension. If you see that there is a movement in the vertebrae above and below, and there is you see that the nerve is getting impinged, then these are the indications where you may think of stabilizing the spine doing an operation. So you have to, there are multiple classifications, Meierding's classification, depending on the percent of slip. So based on the percent of slip, if it is grade 3, grade 4 above, then we sometimes do surgery to relieve symptoms. Less than 50% slips usually do not require surgery, and a simple muscle strengthening protocol or rest with painkillers and avoidance of high intensity activities usually relieve symptoms. Operation is required if the persistence of if there is persistence in the symptoms for more than 1 year, the back pain is not going, the leg pain is causing disability to the patient, and there is progressive neurological deficit. In such cases, you may require to undergo surgical procedure. So, what surgeries do we do? In low-grade spondylolisthesis, we may just do a surgical repairs of the pars interarticularis defect. But if the grade of slip is more, then we may need to fix it using conventional screws and rods, and also decompress the neural elements which are getting pressed. Sometimes we also put in cages. That is a metal piece which is usually put between the vertebra above and below, so that the height of the vertebral column can be maintained, and also giving the spine its stability. Nowadays, uh, many people are also doing artificial disc replacement. The benefit is that it is motion preserving, and the chances of facet joint arthritis are low, but the only contraindications are if the patient is already having facet joint arthritis, then this procedure cannot be done. And you should also know when to refer the patient. So, as I told you, cauda equina, severe radiculopathy, unstable fracture, or progressive neuropathies, these are the immediate uh, patients which should be referred immediately. Others are patients having continuous back pain which is not getting relieved by any of your conservative management. You suspect a cancer or neoplasm in the spine. The diagnosis has not been made, and the patient is running around doing multiple uh, medications, but still not getting relief. Then these are the cases which you should refer to a higher center or a spine specialist. Now let's see some cases. This is a 38-year-old gentleman with no history of back pain, developed acute pain after lifting two heavy boxes 2 weeks ago. So what do you think is the diagnosis? He denies any leg pain, no history of fever. So definitely this looks like a mechanical back. Another patient, he was 20 years old. He has pain and stiffness in the back for more than 3 months, but there is no history of injury, and his pain worsens on getting up in the morning, and it lasts for more than 1 hour. So, but this pain, when patient says gets relief by taking anti-inflammatory, so definitely the patient is having some sort of inflammatory back pain, and this needs to be investigated, diagnosed, and treated accordingly. A 9-year-old boy comes to you with low back pain, yeah, and it is pretty severe. Around on a scale of 10, he gives this pain 8 or 9 marks. There is also some radicular shooting pain in the right leg, and there is decreased sensation. So definitely, you should think in the direction of a disc prolapse, get an MRI and see where the nerve is getting pressed and get it treated accordingly. Another man, he is 70 plus, comes to a general practitioner with low back pain, which is new in onset. The patient gives history of prostate cancer, which was diagnosed 2 years ago. So this should, immediately ring a bell in your head that this could be a secondary in the spine. This could be cancer, and you should get the patient investigated accordingly. So what are the take-home messages? Proper diagnosis is the key. Look for the red flags. You should know more than when to operate, you should know when not to operate, when to refer the patient, and just remember only 15 to 20% of spine patients need surgery. Majority patients, if treated properly in time, can be managed conservatively. And with that, thank you. And I would be happy to take any questions regarding spine problems or other problems in orthopedics if you may have.